This is Psychotherapy Part 3. All right, so we just covered ACT, and now let's talk about, we've mainly been focusing on individual psychotherapy, but let's talk a little bit about advantages and disadvantages of group psychotherapy. I can tell you that our counseling center runs quite a few groups, and there are some reasons why that's very popular in counseling centers across the country for college students. So when we look at advantages of group therapy versus attending individual therapy, it is cheaper to pay for group therapy than individual therapy. The therapist is able to help more people at one particular time. Keep in mind, a typical psychotherapy session for individual therapy runs about 50 minutes. Groups tend to do more like an hour and 20 minutes to give people more time to share with one another and to process things. People in groups are able to draw on more experiences. So it's not just the client's experience or the therapist's experience, but maybe other clients' experiences and how they got through that. A good example of that is Alcoholics Anonymous, Narcotics Anonymous, where individuals will get a sponsor who is much further along in their sobriety. And so that sponsor oftentimes, because they're further along in their sobriety, does a lot more sort of supporting and giving advice and helping individuals figure out what to do when they're earlier on in their treatment. So that can be really helpful. Lots of social support, just like I talked about with the sponsors in NAAA, this idea that we are all in this together. And so I know when I've worked and I processed eating disorders treatment groups, one of the things that I had to be careful about was, and this would happen like every now and then, I kind of walk into the group and they would have just already be talking with one another before the therapist arrived. And what I would overhear might be some really unhelpful things that they were sharing with one another that I would have to redirect back to the appropriate social support. So an example would be walking in on a conversation about, well, this is really easy to throw up. This is really difficult to throw up when you eat it. And having to, go, wait a minute, we're all here. We're here to support everyone's recovery. Do you think that's a good thing to be talking about? Or do we want to redirect it back to, when you wish to binge or you feel the compulsion to purge, what other ways do you find coping techniques to be able to handle that so that you're engaging in recovery behavior and not eating disorder behavior, as an example? For a lot of individuals being in a group, it just helps to normalize problems. One of the examples I gave earlier in the semester was group therapy for people with social phobia and social anxiety. And when I first heard about that, I was like, oh, that'd be a nightmare to run as a therapist. But what I heard from my fellow attending psychologists and my fellow interns was that it was a wonderful way for people with social phobia to realize there are other people like them, and there are other people whose lives have been disabled because of their social phobia, and they were other people where they could practice their social skills with, instead of practicing those skills with people who are really socially smooth, that kind of thing. And another wonderful thing is that one of the things that can happen in groups is that instead of a therapist trying to gently call on a person for their behavior, a lot of times people in groups will just do that. So you might have somebody talking about an ineffective coping technique or something like that, or thinking that they were doing the right thing when really they were doing illness behavior instead of recovery behavior, and group members just being like, girl, you don't know what do you realize what you just said? And that kind of thing. And they can just sort of like, call people out on what they need to be called out on to help them change their behavior. Some of the disadvantages is not as private. Not as individualized, because in one-on-one therapy, the therapist is going to be all about what that one particular client needs. Keep in mind, with the privacy issue, a lot of times there are confidentiality rules, though, for groups, and the rules get laid out early on by the therapist to the group. So an example would be, Alcoholics Anonymous, Narcotics Anonymous, as an example, I keep using those. Those are not necessarily therapist-run groups. Those are the people, the actual clients run the groups. But the anonymous is there for a reason. Those groups are confidential. Okay, and so certainly sponsors and their sponsees may talk outside a group, but anything that is said in group by any of the people is kept in the group. And so it's private, and there's honor there in that. So that if I were to go to NA that, and let's say, I don't know, I was going up for a political office or something like that, the members in the group should not be disclosing to the public that I've had a narcotics addiction history, as an example. And then it may not be as tailored to one's treatment needs. So we've got advantages and disadvantages. The reason why a lot of college student counseling centers do quite a bit of groups is, well, certainly a lot of college students are sociable, and it just kind of fits with them, but they're able to serve a lot more students effectively than if they were trying to see everybody one-on-one. So then this is the question, is psychotherapy scientifically effective? And the answer to that is yes. And there are a variety of different ways that, and these are the psychological scientists, so these are mainly the PhDs that are studying these kinds of things. There are a variety of different ways to study it. One study, as an example, this is a dated study, so it's pretty old at this point in time, but it was a meta-analysis of many psychotherapy studies. And a meta-analysis is when you take one study and another study and another study, instead of each subject in your study being one participant or one subject, each subject in your study is a whole study. Okay. And there are usually inclusion criteria of what are the good studies to pull together and include. But in this way back in 1980, found that 85% of the participants who were randomly assigned to no treatment had poor outcomes than those randomly assigned to the psychotherapy. So even though you're taking these people with all these different kinds of illnesses, and you're randomly assigning some of them to get psychotherapy for it, some of them to get no treatment, the psychotherapy people were in much better shape following their treatment than those who were in the control group who didn't get the psychotherapy. And we know this is why they're called randomized clinical trials. And this is what the FDA requires in drug research, as an example, medication research. And ideally, we do this in psychotherapy also. Finding the appropriate control group or finding an appropriate placebo in psychotherapy gets a little bit tricky, whereas that's much easier, say, in drug studies. But there are ways that we do that, and there's ways that you do that scientifically well. And I know we are way far away from 1980 at this point in time, but I can tell you there have been all kinds of studies and meta-analyses on different types of psychotherapies to show their effectiveness. And we know psychotherapy helps people in these scientific clinical trials. So as an example for treatment of eating disorders, I know from the scientific research, medication alone is not recommended for eating disorders. Psychotherapy, there are ACT, CBT, and interpersonal therapies, IPT, as well as family system therapies that we know have good scientific evidence for treating eating disorders. I also know when you look at the research relative to combining medication with psychotherapy add to the treatment outcome in eating disorders, we tend to see the answer is actually no. So medication alone, not recommended. Psychotherapy, really good. Psychotherapy with medication, that maybe not additive, but it's really the psychotherapy components that tend to be effective. We also know from this research that CBT, and I'll add to this, it's not on the slide, but I will add to this ACT, is especially helpful for behavioral disorders. So doing the ABCs, manipulating antecedents, manipulating consequences, teaching people skills, getting in there and undoing anxiety associations that we've talked about with like exposure therapies. That is going to be so much better for behavioral disorders like addictions, like eating disorders, like we talked about in sexual dysfunctions, than simply talking about it in a talk therapy. There are certain places where you can talk about stuff till you're blue in the face, but until you get in there and you understand what is driving problematic behavior, then you're not going to be able to change it. Okay. So there's a reason why ACT and CBT are better. Another way of studying the effectiveness of psychotherapy is to actually study the people who have done it. Okay. And Consumer Reports, that's the magazine where they put out, like, if you want to buy a new SUV, you might go to Consumer Reports and find out, okay, I want an SUV in this price range with great safety, great traction in four-wheel drive, because I drive on ice and snow and Boone in the winter. I want those anti-lock brakes because that's going to protect me on those snowy, icy hills, that type of thing. And then let's say I find out that Consumer Reports has tested all these different models, and then I find out that, say, the Nissan four-wheel drive is much better than the Hyundai. And I'm making this up. I don't know about Nissans and Hyundais, but then I might, instead of going out and saying, well, I kind of like the looks of this a little bit better, but Consumer Reports has told me this is the better vehicle to purchase. And so then I listen to what the science says. In a Consumer Reports study of people who had done psychotherapy, they said the psychotherapy helped them. But there's some interesting kinds of caveats here, and I think these are kind of interesting, especially if they got to pick their own therapist. So my recommendation, if you decide to start psychotherapy, there are two things you want to find in your therapist that are imperative and very important. Number one, that your therapist is licensed in your state. I am licensed as a licensed psychologist. Social workers get licensed at the social work board. Medical doctors get licensed at the medical board. You can look this stuff up online. You can find out who is licensed in North Carolina under what professions. That is public knowledge. And we had to go through a process for that. I had to take a national exam and pass it, a state exam and pass it. I had to do 1,500 supervised postdoc hours after I got my PhD before the state of North Carolina would license me. So you know that person is well trained and credentialed when they are licensed. It's not a certification, it's a licensure. Okay. Second thing, that you like that person, that you feel comfortable with them, that you feel like you can do your work and trust that individual. That's very important. My mom took me when I was a teenager. So my first OBGYN appointment as a teenager, she took me to her doctor, and he was an older man, and he could not, when I was just sitting in the chair with my mom beside me with this doctor, he could not look me in the eyes. And I had not done anything bad, but it was just terribly uncomfortable that this person didn't have the normal interpersonal skills to talk and interact with me and make normal eye contact. And after that, I told my mom, like, I don't know. I don't feel comfortable around this person. I don't want this person to be my doctor in that way. So you need to feel that kind of comfort. They also found if they had unlimited sessions rather than time-limited treatment. So in the old days, a lot of the health maintenance organizations, the insurance companies, would limit the amount of treatment that people got, and you'd have to jump through all these hoops and sort of beg for insurance coverage if you needed to go beyond that. Counseling centers tend to follow time-limited treatment models. So they bring, as clients come in, they will interview them and decide if they can do time-limited treatment, and that would be effective for that person. If they feel like they're going to need more lengthy treatment, they oftentimes take the students and refer them out into the community to see somebody privately in the community. It makes sense that if you had unlimited, you do your work. Sometimes you do work on X, that kind of thing. And after you get past X, then you want to work on Y kind of thing with your therapist. But it makes a lot of sense that it's going to be tailored to you and your needs. And you end, or they call it terminate in therapy, which I think is hilarious. It sounds like we kill people. But when it's time to terminate with a client, you know that they've done what they needed to do. They're feeling better. They feel like they have really been helped. So it makes some sense that unlimited versus time limited. They found that the type of therapist, whether it was a counselor, psychologist, psychiatrist, social worker, did not matter, with one exception, but I want to explain this one exception. They found that marriage and family therapists were not rated as effective as counselors, psychologists, social workers. But I don't think that's because marriage and family therapists aren't as skilled. And in fact, I trained under marriage and family therapists in an inpatient eating disorders program. And it was a wonderful experience for me as a psychology trainee to get outside my comfortable box and learn how to think a different way and learn how to do things a different way. This is likely because a lot of couples hold off on going to couples therapy, like marriage therapy, as an example, until things are really, really bad, until somebody has cheated, until somebody has asked for a separation kind of thing. And we know that the earlier an individual goes for help with an individual problem, the better the therapy and the faster the therapy is going to be. But especially with couples, if they go when they are starting to struggle and get some help, that's going to be much more effective than a last ditch effort to save them, because a lot of times things are way too far gone at that point. I had my former pastor gave a children's sermon to the children before the sermon, where it was basically sort of an acceptance that we're going to still love everybody, even if they have been partnered and legally divorced. Like, we're not going to shun individuals for divorce in our congregation. And the sermon that he gave to the little kids is he had them take a tube of toothpaste and he had them squeeze out all the toothpaste, and they had fun with that, like kids would. And then he said, put the toothpaste back in. And the kids were like, what? And, and they were like, that's impossible kind of thing. And then in the adult sermon after that, it was sort of like, sometimes in relationships, all of the toothpaste has been squeezed out. There's no going back. Okay. And for a lot of people who have ended longer term relationships, will say that, things have gone too far. Things have been said. You can't go back. It's time to become a single person and try to grow on your own, or maybe at some point in time, begin a new relationship with a new person, and maybe ideally try to do things differently in that new relationship. Okay. We find here that about 31 to 58% of therapists identify as eclectic. And those who identify as eclectic tend to be older therapists and therapists with more experience. And being eclectic would mean somebody can borrow from a variety of different psychological orientations. So at times they can think psychodynamically and treat psychodynamically. At times they can realize, okay, ACT is going to be better than CBT for this. Or they can think family systems like the marriage and family therapist would. But the reason why it makes sense that older, more experienced, is they've had more time to learn the different models. And then, very much like building a toolbox that is a very rich toolbox, realizing which tool works with what problem at any given time. Is this a nail hammering kind of problem? Or is this I need a screwdriver and first I need to drill before I put in a screw kind of problem? The reason why we don't train students, though, to be eclectic from the get-go. So keep in mind, most master's programs in clinical psychology are 2 or 3 years long. Most doctoral programs in clinical psychology, whether you get the master's degree on the way or not, tend to be 5 or 6 years long. Is that there's so many skill sets that we train for our psychologists: assessment skills, therapy skills with children, therapy skills with adults, some of the neuropsych stuff that we talked about when we talked about dementia, lots and lots of skill sets. But you tend to train in one model. Like, our program is CBT and ACT. Like, that's the main training point that all of our faculty are doing with the graduate students in all of these classes. The reason for that is we've got to give them, it's kind of like learning that foreign language. We've got to give them a way to think and conceptualize and to diagnose and to what tools to reach for that we know are effective for these different problems. If we try to train them to be eclectic from the get-go, it'd be like trying to train surgery on a first-year med student. Like, they don't have enough knowledge to know how to, even to start to understand that that early in the medical training. So we got to teach them how to think. And then they grasp like, okay, here's this client. I know how to think. I know how to diagnose. I know how to conceptualize. I know how to treat. And then they get effective at it. And then they realize, okay, these things work with these kind of clients. These things work with these kind of clients. And then over time with more experience, they can kind of branch out and roll in more stuff, more techniques. Okay. Know that the American Psychological Association, so I'm a member of Division 38, which is the Clinical Health Psychology Division, because that's my area of specialization, that all of the divisions are evidence-based. And so you can get online if you want to look up apa.org and look up some of that stuff. Another organization that I belong to and most of my clinical colleagues belong to is ABCT. And that's the Association for Behavioral and Cognitive Therapies. Normally we would go to a conference every year, not this year during the pandemic, but I had presented my students' research there. I have done a lot of training when I go. I really kind of caught up in learning ACT when I would go to that conference. Okay, we're switching gears. And now we're going to talk about psychopharmacology. You can see it in the roots of the word here. We've got the psychological, and then we're using the pharmacy as the treatment. So this would be using mainly medications, but sometimes procedures or surgery to treat individuals for their psychological disorders. Now, I want to start off with talking about the psychologist's role in this. So psychiatrists and other medical doctors can prescribe psychotropic meds for psychological disorders. We psychologists do not prescribe, but having said that, there are subgroups of psychologists, particularly psychologists that have worked in the military, who have deliberately gone and trained in psychopharm. And there are some programs across the nation where psychologists can go and seek additional intensive training in psychopharm, and those particular psychologists can prescribe. And again, it makes some sense that in the military, they can do both. They can do talk therapy and they do prescriptions. Some who have retrained, although what I've known most happens, which is kind of interesting. I've known more psychologists who get their PsyDs or PhD in clinical psych, then they return to school and get like a physician's assistant degree, where with the PA, they can prescribe. That is, so about a 2-year training program. And there are some individuals, particularly serving rural areas, who've done that. So they're a jack of all trades. They can do the psychotherapy stuff, the testing, they can do the prescribing. It is our role, for me, not being medically trained in this regard as a clinical psychologist, I assess for meds use, and I also assess for supplement use and other substance use. Because if I've got a client, let's say, doctor has given her antidepressant medication, I also know that my client is taking herbal supplements like St. John's wort, and my client drinks very heavily on the weekend. If there is not a medical doctor that is aware of that, I'm going to talk with that client, and I'm going to encourage that client to go talk to her, the prescribing medical doctor who's prescribing the antidepressant. Somebody needs to know that and be on top of that, because that is dangerous, those combinations. So assessing for it. But again, I'm not changing prescriptions. Okay. So I would not be saying, oh, well, if you're going to be drinking, you got to stop taking the antidepressant. That is not ethical for me, according to APA ethics and according to my license. Knowing about the physician's desk reference. So knowing how to look stuff like that up. And understanding that. So let's say, for example, I've got a client who's got a really severe depression and their nurse practitioner put them on an antidepressant, but they have not raised the dose. And let's say I find out that they're like on 10 milligrams of Prozac. I could go in the PDR, physician's desk reference, and look that up and then realize that's a starter dose. That's basically, it's not total placebo, but it's a starter dose and is usually not effective long-term in treating severe depression. So what I would do, again, I would not say, hey, double up, triple up your meds, because that's not my license. I would say, you really need to make another appointment with your nurse practitioner and go back and let her know that you've been taking the antidepressant for about 4 weeks now, but you're not feeling any treatment effects. And so send them back to consult with the appropriate professional. We do a lot of consultation, let's say, with physicians, and letting them sort of know, like as an example, let's say I've got a physician that wants to start an antidepressant on a client, and I have done a thorough diagnostic evaluation, and I know they're not clean depression, they're bipolar. That would be really important for that physician to know, because if you send somebody who's bipolar and depressed and you put them on an antidepressant, you usually send them into mania, which can be very hazardous if they've got some serious consequences in their mania. So what I would do in that situation, if the physician is asking me, is I would clarify that I think the true diagnosis here is bipolar, not major depression. And my advice would be, do you want to consider, if it's not a specialist, it's not a psychiatrist, you might want to send them to a psychiatrist. Or would the physician feel comfortable starting with a mood stabilizer? And once we get that person stabilized and not going into mania, then if they're still depressed, then maybe adding an antidepressant on after the mood stabilizer. So sometimes we consult. Okay. But again, we're using our knowledge base. We're not practicing medicine. We're not telling the doctors what to do, that kind of thing. But it's good. And a lot of times the medical doctors, they want our advice. We want the medical doctor's advice, that type of thing. Another thing that we sometimes do is if we've got a client who's been prescribed medication that could be lethal in an overdose, and we've talked about this in suicide, doing CALM, counseling against lethal means, we might get back to the prescribing doctor and suggest, is it possible to consider a medication that is less lethal in an overdose? That was really problematic with the tricyclics, that we're going to talk about here in a bit. And then we document anytime we have like these conversations, like I really want this client to go talk to their doctor about what they're taking, or I just talked with their doctor. We document in notes. We document our therapy all the time, anytime after we have contact with a client or anybody relevant. And then we also inform individuals about talk therapies that can be alternatives to medications. And so as an example, we're going to get into the antidepressants here in a bit. But the research suggests that for mild to moderate depression, it's actually better to do psychotherapy and not use medication for the long run, because using medication for mild to moderate depression actually is a predictor of more relapse with depression than having used psychotherapy alone, as an example. So let's talk about the minor tranquilizers. These are the meds that are used to treat anxiety. They are sometimes used for sleep. And these are commonly called the benzodiazepines or the antihistamines. So you all probably know the effect if you've ever taken Benadryl, like you got stung by a bunch of bees and you took Benadryl, how sleepy you get, because the antihistamines tend to have that effect. The benzodiazepines are the things that you all have probably heard of like Klonopin, Xanax. These meds are very effective at tapering anxiety, creating relaxation, helping people sleep. Problem is they are highly addictive, okay? And so people, might get short-term prescribed Xanax for a particularly stressful period where they lost their job or their significant other broke up with them. The problem is a lot of times they have to start using more and more and more to get the same effect. And then there's this whole withdrawal issue. And it's one of those, like if I'm counseling clients about this, or I'm talking with the doctor about this, it's like you thought you were anxious and had problems sleeping before you started taking these medications. And then you now built up the dose in these medications to get the same thing. You thought you were anxious and stressed before? Wait until you try coming off of this stuff. Okay. And there's this thing called rebound anxiety. And so what the medical doctors should be doing is, anybody who wants to get off these meds is tapering them and not going cold turkey, because cold turkey is going to be gnarly withdrawal. Another example would be alcohol is a sedative. And if you've got somebody, let's say in an emergency department, and they are having horrible withdrawal from not having had their high dose of alcohol in a while, then the medical doctors will give them a banana bag. And a banana bag is where they will feed them low doses of alcohol intravenously and then taper that alcohol until they can come off and get sober off of that alcohol, detox off of the alcohol without all of the gnarly anxiety. So this is really meant to be very short-term treatment and not a long-term solution to sleep issues or to anxiety. Nowadays, what a lot of psychiatrists will do, and I appreciate this, is they're more likely to prescribe antihistamines for sleep or prescribe the tranquilizing antidepressants instead of these anxiolytics, instead of these benzodiazepines for something like sleep. And a common one, like the VA system uses this a lot, and I've had quite a few clients that have been on trazodone. Trazodone is a sedating antidepressant. It is not an anxiolytic. So it's not the kind of thing that they're going to build up, habituate to. It's not the kind of thing they're going to need more and more and more of to help provide them with some effective drowsiness. The major tranquilizers, these are more likely to be used to treat mania and to treat psychosis like schizophrenia. These are the phenothiazines. We talked at the very beginning of the semester how sort of the field of psychiatry was almost born out of accident, where they realized that people with mania or schizophrenia who were institutionalized, when they would get colds or allergies and they would prescribe antihistamines for their colds or their allergies, not only would their stuffiness kind of clear up, but their head would get clear. Like they would come out of the delusions and come out of the psychosis. And again, so sort of by accident, people with schizophrenia get colds and allergies, that kind of thing. Then they realized that by prescribing these meds, some individuals, it was an effective treatment for their psychosis or their mania. The problem with the phenothiazines used for a long period of time, and people with bipolar mania and schizophrenia oftentimes will need lifelong treatment, is that these medications cause a Parkinsonian condition called tardive dyskinesia. And we talked about this when we talked about schizophrenia. So abnormal movements, weird and odd kind of facial movements. And so nowadays, when people are on these meds long-term, they will prescribe other meds like Cogentin to try to slow down the development of tardive dyskinesia. The modern medications, so an example would be like Zyprexa is modern. Haldol's been around for quite a while, but the more modern medications are gentler in terms of creating those long-term neurological effects, as well as showing some better effectiveness. So the antidepressants, these are also called the anti-obsessionals. There are three major categories of these over time. And the first one I want to talk about are the tricyclics. And these are medications, some of you have heard of some of these like Elavil, and then a lot of the amines, the amitriptyline, disipramine meds. Are equally effective as some of these newer medications. But there's some problems with the tricyclics. First of all, you would have to take them 4 to 6 weeks before the real effect kicks in. That's the same for the SSRIs down here below. Another problem with the tricyclics is people would get what are called these anticholinergic effects. And so it'd be things like dry mouth, constipation, weight gain. And so you can imagine these side effects for clients. It's like you thought you were depressed back then. Well, now you got to be, I'm just drinking water because I'm talking a lot. Now you're thirsty all the time. Your mouth's dry. You're getting cavities because you got no saliva. You've gained weight and you're constipated. You can't go to the bathroom when you need to. It's like you thought you were depressed then. Imagine how depressed you are now with these side effects. Add to that, the tricyclics were very dangerous in an overdose. And so unfortunately, what was happening when these were the babies of the antidepressants. So these were on the market well before these other things. And what a lot of doctors were doing, not being well trained and not knowing how to do that, is you'd have a client come to them and say, hey, I'm really depressed. And they would say, okay. And they would give them 3 months supply of tricyclics, send them out. They're taking these meds. They're getting those side effects. They're not getting relief because they need to know. Sometimes it takes a month to 6 weeks for the benefit to kick in. So there they are having side effects. They're still depressed. They had hope in a bottle, but that hope hasn't occurred. What if they become suicidal? And what if they go, hey, what if I take all of these at once? So doctors were handing over the means of suicide to these clients. And now they're no longer doing that. But we had a lot of people who effectively were killing themselves on these meds. The MAO inhibitors are a special kind of chemical antidepressants, and these tend to be used for special cases. So as an example, seasonal affective disorder or depression where you have that hibernation kind of symptoms, where you've got the hypersomnia, the weight gain, the appetite increase, the lethargia, that kind of thing. They tend to work a little bit better for that unusual kind of depression as opposed to the typical symptoms we usually see in depression. Other issues with the MAO inhibitors is that individuals have to be very careful with their diet, and they have to avoid a protein called tyramine. And tyramine is in everything that I consider to be fun. And so these are my fun consumption things: cheese, chocolate, and alcohol. And so clients have to be very careful not to eat certain foods that have that amino acid in it when they're on the MAO inhibitors, or it can cause a hypertensive storm. It can make them stroke out and die or give them a heart attack. And I gave an example about my weight management woman who was on her MAO inhibitor and she wanted a banana. She wasn't supposed to have a banana, but she ate her banana anyways. And she didn't die apparently from it. Another thing that people on MAO inhibitors, if you take any kind of cold medicine and you check out, or a lot of allergy products, and you check out the back, the warning labels on cold meds, allergy meds, it will say, if you're on an MAO inhibitor, do not take this medication. So they have to be very careful about diet, have to be very careful about their use of certain over-the-counter meds. So the SSRIs, these stand for selective serotonin reuptake inhibitors. Select serotonin reuptake inhibitors, SSRIs. These are the modern antidepressants. And the first one that was ever put on the market was Prozac. And I can tell you psychiatrists don't exactly know what is going on chemically. But one thing that happens between two nerve synapses is if you send across the serotonin and it locks in and it sends the signal on this other synapse, there's a recycling process that goes on. Our brains good at recycling, good for the environment. There's a recycling that goes on, and the quicker it can recycle, the quicker that serotonin is back in that synapse and it can send another signal. I am a psychologist and I watched the Zoloft commercial with the egg. So you'd see them advertising Zoloft and you would see this egg. And it took me, maybe I'm dumb at times, that I do know. I was like, what on earth does an egg have to do with Zoloft? What on earth does an egg have to do with your brain? And then it was like, oh, it's the egg's the serotonin molecule. Duh, that's what it's supposed to be. But anyways, it took me a while to kind of understand that. So what these SSRIs, what psychiatrists believe they do is they make more serotonin available for use, because we know low serotonin levels are associated with depression. They're also associated with inflammation in the body, so physical illness and inflammation. So it's giving them more serotonin to use. In one study where they looked at, it's called STAR-D, and they looked at different sequence treatment alternatives to relieve depression using SSRIs, they found about 33% of people go into remission by about 12 weeks. Again, these antidepressants do not work quickly. They found that taking antidepressants actually helped with suicidal thoughts, and they did not see because there was a worry for a long time that you could be depressed without suicidal thoughts. But after you started taking an antidepressant, then you could get suicidal thoughts or want to engage in suicidal planning and suicidal behavior. They did not find that it creates new suicidal thoughts in clients who didn't already have them, as well as it helped. But even those with a positive response to their depression still continued having symptoms of depression longer term. So symptoms of insomnia, symptoms of sadness, problems concentrating, problems with decisions. And so what we've got here, and this is what the scientific research suggests, you've got to be able to show that your medication improves symptoms above and beyond placebo to get FDA approval, to get that medication on the market, like they were able to do with Prozac for the first SSRI. However, I can tell you the effect size above and beyond the treatment effect for placebo for depression and anxiety is minimal. The majority of the effect is placebo. It is, I'm feeling crappy. I've gone to my doctor. My doctor has given me this medication. I want to feel better. I am going to take this medication as prescribed because I really want to feel better. That's placebo. A lot of that is belief. It is the placebo effect. So again, antidepressants had to show they were effective above and beyond to get on the market as a pharmaceutical, and they had to prove that they were safer. The SSRIs are much safer in an overdose. Okay, so that's a real nice thing they've done beyond the tricyclic. They tend to have less of those anticholinergic side effects. So the less of the weight gain, the less of the dry mouth, the less of the GI, stomach issues and constipation, that kind of thing. Other meds that are used to treat depression and treat the anti-obsessionals would be, these medications tend to be quite effective in helping, in addition to therapy, OCD, sometimes generalized anxiety disorder, sometimes panic disorder. Other medications on the market, norepinephrine reuptake inhibitors, dopamine reuptake inhibitors. So an example of one that does both of this would be Wellbutrin. It's marketed as Zyban for smoking cessation, Wellbutrin for depression. Stimulant meds tend to be mainly used for ADHD, and at times stimulants are used to jumpstart another medication that is not quite fulfilling its effectiveness. But mainly these stimulants like Ritalin, which is methylphenidate, as a stimulant med is used to, and Adderall, and some of these others that are stimulants to treat ADHD. And remember, we talked about stimulants inhibit the brain. The brain is able to put on the brakes. And so as an example, a lot of us will use coffee that way, that we find when we drink coffee, we can concentrate more on our work. Like I do my best writing when I'm writing research up in the mornings. And it's in the mornings after I've had breakfast and I've had my coffee, and I find that I can concentrate more thoroughly after coffee, but then I can also concentrate more thoroughly after exercising, which I tend to do mid-morning on most mornings. So stimulants disinhibit, sedatives like alcohol disinhibit. Got it? Stimulants inhibit, sedatives, depressants disinhibit. All of these meds nowadays come in, they can come in smaller doses that are longer acting, which tend to be better than a big dose early in the morning for some individuals. You've got to be careful. This tends to really help individuals with ADHD focus, but keep in mind, all of us, if we took stimulants, it would help us focus more. We've got to be careful with side effects. A lot of these individuals will suffer from insomnia because of taking the stimulant, so timing when to take it can be helpful. It's my philosophy that particularly when we put children on these meds, that there are times when the kids are on the meds in school and teachers are doing ratings of the students' behavior. And there are times that the kids are sent to school and they either are given a placebo by parent or guardian, or they're not giving the meds and the teachers are doing ratings, where you're actually getting some behavioral feedback. Is the medication making a significant difference at school, as well as is it making a significant difference in that child's behavior at home? Insomnia is common. Weight loss is common, or lack of growth, lack of weight gain is a potential side effect. Some of these other meds that are used to treat ADHD are not stimulants. And so as an example, Vyvanse is a med that was used to treat blood pressure, and people with ADHD found that when they were treating their blood pressure, they could really focus better. So it was the kind of sort of discovered by accident. Strattera, the norepinephrine reuptake inhibitor, is not this is more like an antidepressant than a stimulant medication. It's not a stimulant. And so these are the meds used to treat ADHD. The mood stabilizers are mainly used to treat bipolar, but they are sometimes used to treat chronic pain, particularly migraine pain. They are also anti-epileptic drugs, anti-seizure drugs. And then at times they are used to treat borderline personality disorder. The most well-known is lithium. I listen to Sirius XM, channel 34 is the lithium. It's the grunge station. Lithium, named sort of after some of the artists in the 90s who played grunge, like the lead singer for Nirvana. Lithium is a simple salt. It is a very cheap medication. It's not expensive. The only issues with lithium, it's very effective at controlling mania and bringing people down from mania, from a manic episode. The problem is it's hard to dose the lithium based on one's body weight. One of the reasons why the nurses in a doctor's office weigh us is in case we need a medication. They usually dose our meds based on our body size and our body weight and our gender, our sex, male, female. Lithium, you have to be able to dose by measuring it in the bloodstream. And so a good psychiatrist or psychiatric PA or nurse practitioner will see that patient on a regular basis, take regular blood draws, and then dose it at an accurate level in the bloodstream. Another reason why medical professionals should be monitoring the lithium in the bloodstream is to make sure that that patient is truly taking their lithium. Because a lot of times what happens in people with bipolar disorder, the meds do a good job of keeping them out of mania, but they don't do a great job of keeping them out of depression. So there are quite a few individuals out there who stop taking their their lithium, so they can go into a more pleasurable mania, but that can be really dangerous, okay? And again, a good doctor is monitoring this on a regular basis, dosing it according to their bloodstream and not their body weight, making sure they're taking it so that they're not tinkering with their meds to send themselves into a manic episode. Other meds like valproic acid or Depakote, Tegretol was mainly was used for seizure disorders. Neurontin, Lamictal is used a good bit in these meds. ECT, electroconvulsive therapy, I want to give you a little bit of how this was used historically versus how it's used today. If you have not seen or read One Who Flew Over the Cuckoo's Nest, it is a very powerful book and movie about mental illness. And Jack Nicholson played a kind of a crazy fella and had ECT used as punishment back in the old days. So electroconvulsive therapy, the way they used to do it is they would strap a patient in, and they would take electrical elements and put it on both sides of the brain, which would send the brain into a seizure, which would send the whole body into a convulsion. So they would be strapped down to keep them from jerking around. They would put a device in their mouth to keep them from biting their tongue or swallowing something, because it's a full-blown seizure. The way it was done on both sides of the head in the olden days, and then it was used as punishment for oftentimes inpatient psych inmates, really, patients who were misbehaving. It was used to subdue them. It was used to punish them. And then real sad scene in One Who Flew Over the Cuckoo's Nest on that. And when it was used to control them. And that was very sad. It would subdue people because it would basically fry their brain, and it would remove memories, particularly long-term memories. So you would have people who were on ECT who couldn't remember their wedding, let's say, if they got married, or they couldn't remember the birth of their children, or their children graduating high school, things like that. So really sad, or who they were, or who they were partnered with, that kind of stuff. Nowadays, it is used much more selectively, and only when other things have not worked and you've got really severe debilitating illness. So I worked with a client at one point in time, very severe depression, who couldn't even participate in psychotherapy. He was so depressed. And after ECT was well enough to participate in talk therapy, as an example. So it's used much more selectively, and not just, universally to subdue or punish patients. It is only, they put the electrode on only one side of the brain. And instead of restraining them and putting something in their mouths, they still do kind of put mouth caution. They will use medications that will temporarily relax their muscles and temporarily paralyze them. So even though their brain is going into a gentle seizure, their body's not experiencing the convulsions. Because patients will report, think about like getting, you get a cramp like a Charlie horse in your calf. Imagine if all your muscles in your body were going into convulsions and into that kind of cramping. Imagine how miserable and sore you would be after something like that. So today it is much more humane. By doing the one side instead of the both sides, there's a lot less memory loss. And we used to, and again, this was kind of facetiously said, if you can't remember why you're depressed, then maybe you're not as depressed. Nowadays, people preserve more of their memories. It is a treatment. It is not this kind of thing that tends to be done once. It tends to be done for, again, these really severe clients more than once over time. And I think with that, I have covered the models of psychotherapy. We have covered group, individual. We have covered the psychopharmacology. We have covered the types of professionals that practice these different types of mental health treatments. And on that end, we are wrapping up the class. It has been a pleasure to teach you abnormal students. Good luck studying and getting prepared for the final exam. Get in contact with me if you've got any questions as you prepare. But I'm going to say last lecture. See ya. Bye-bye.